This conference will now be recorded.
Welcome to the Priority Principle, a clinical guide to laser therapy dosage. My name is Douglas Johnson, and I will be your host today. Notice of copyrights. The Priority Principle, a clinical guide to laser therapy dosage, is copyright 2023 and is listed as private and confidential. Today on our agenda, we are going to understand the critical role of the Priority Principle in laser therapy. We're going to talk about how to prioritize the patient's unique physiological and functional needs to help build our treatment plan. We're going to talk about how to discuss and select the correct priority for maximum therapeutic response. We want to explore how the priority principle ensures reliable results across diverse patient populations. And then I want to give you some insight into seamlessly integrating the priority principle really into clinical practice to give us some enhanced patient care. So the reason why we're all here is we want to know how to use laser therapy. And this has always been the question when we go to teach. It's I understand the theory, I want to figure out how to put it into practice. And one of the ways that we do this all the time is people just say, well, give me a cookbook, give me a recipe. I just want to understand what buttons do I push and give me a list of a recipe. And we've done that in many situations. We've created standardized treatment plans. The problem comes in is that there's a great deal of patient variability. And different patients may have different symptoms, and different patients may have different stages of healing, and therefore it starts to create this multiplicity, and where we can end up getting 10, 20, 30 different protocols for the same type of injury. And this is something that we did when we first were developing the priority principle, is that our group got together and we said, hey, we're going to write a cookbook. We're going to write a laser therapy textbook of protocols. And when we all got together, we all found out we had 10 different protocols for how we treated the ankle. And this brought up a big dilemma of how do we teach something to be consistent, produce reliable results when we as a group don't have this common language. We weren't even agreeing to what the best protocol was at the time. And a lot of this was we started to look at a lot of the protocols had some overlap. And what we had realized is that several of our clinicians treated patients at different stages of healing. Some people treated very acutely, some people treated during the rehabilitation phase, some people treated chronic patients. And therefore, we all had kind of different starting and stopping points. But the one thing that we saw is that these different protocols sort of overlapped. They created this flow or this flow chart of what we were doing. So it wasn't that we were doing something different. We were basing it on our personal experience of what we were seeing with our clinical patient care. So we had thought this was a great idea. And we thought, oh, we could have made this book, but now we're like, wow, we can't write 30 protocols for every condition. And then it starts to become, which one do you use? Do you have this symptom? Do you have that symptom? And so, we really kind of were thinking outside of the box, and that didn't really work. We thought inside the box, and that didn't work. So therefore, it was kind of a defective box, was kind of the way we really felt about it, which is a challenge for us. But we had saw how these had overlapped. And when we started to line these up and look at other different body parts, so, we started with the ankle, and then we started looking at the knee and maybe the shoulder. This allowed us to start to look to see that, wow, we were really all focusing in very specific areas that we were going to do. And it was because we had these three fundamental problems of why cookbook wasn't the best idea for us to move forward, even though we kind of had figured out, oh yes, we were writing the same protocol, but the problem was we were writing protocols because there was different patient variability. So I was seeing patients that were more, you know, acute, and our other KOL was seeing people that were seeing more chronic. And so who am I writing this textbook for? This patient variability needed to be taken into account. The second thing was the healing process variability. So when were we seeing them? And then there was this great overlap. When does the healing phase start? When does it go from subacute to chronic? And all these different variables. When did the patient show up? Am I seeing them that they just get hurt yesterday? Or am I seeing them 6 months, 2 years, 4 years following an injury? So we had this healing process variability that we were also dealing with. And then the last thing is that we were really talking in different languages. So we were multidisciplinary team. So we had some PTs, some ATs, some chiros, some MDs, some veterinarians, and everybody was kind of from a different discipline. And we don't have a shared vernacular for how we do laser therapy. And we don't do that even across the board. So even in different specialties, we might say something different. So like I may call a ligament a certain thing, whereas orthopedic surgeon may call it something else. So we even have these dialects, if you will, in our disciplines for how we talk about patient care and even our patients. So despite that we all kind of talk medicalese or vetnese, if you will, um, we still have our own nuances, our own specializations, our own approaches, and we weren't really reflecting that diversity when we start using these textbook things. So we had to get together. We had to figure out something because if we're going to get laser therapy to be adopted and be understood, we have to be able to teach not just the theory, but the actual practice of it. And how was I using it in clinic? How are our KOLs using this? How are we getting results? And how are we going to share that with our people? And the one thing that we came up with was we started to develop what was now and currently known as the priority principle. And really what it started off was is a kind of a little bit of a dynamic approach to how we were going to see clinical laser therapy. And we had to emphasize that we had to adopt the laser therapy treatment to meet the patient's current physiological and functional requirements. So we had to focus of what was being presented to us. And we were looking at these as where these different symptoms or these different how the physiology was working was really based upon where they were in the healing process. And there were cardinal symptoms and cardinal things that we were treating that we always have to treat early on. We have to deal with inflammation and swelling, and sometimes later on we have to deal with range of motion and muscle strength loss. But we followed that this was really aligning with where the patient was in their healing process. And that was where we needed to start. We had to look to say, well, what if? What if the patient was in this phase? How does the laser therapy change? And some of these things, I won't bore you with them, but some of these things where we had to learn these things. We had to learn what happens when you do laser therapy out of order and I treat range of motion before I treat swelling. Those usually have bad consequences for patients. They get very unhappy when you increase their swelling because you bring blood flow to the area. So we really wanted to make sure that we were catering and actually adapting the laser therapy protocols to fit what we were seeing clinically at that particular moment. So that ruled out, we can't really come up with a cookbook, if you will. So we really wanted to say it's actually applying the right dose. We had to get the right dose to the correct target. So if I'm treating swelling, what are those targets? If I'm treating muscle spasm, what are those targets? And that's what allows us to get the greatest photoceutical response, resulting in not only reproducible patient outcomes, but reliable outcomes. We want them to get the same thing that we were doing inside the labs. So why do we need the priority principle? It's beyond just adapting how laser therapy is brought into practice, but allows us to create a common language between all the different disciplines when we talk about how we're going to treat. So whether I'm treating a pyoderma or I'm treating a lateral ankle sprain in a human, we have to have a common knowledge to understand how this particular modality of laser therapy is being applied. The second thing is we want to treat consistently. If we don't treat consistently, we forget steps. This is why airline pilots have checklists. This is why surgeons have checklists. This is why we have checklists when we go grocery shopping. It's so we can remain consistent in staying to how we're going to treat. Therefore, when we talk to a clinician, we say, hey, oh, you're treating swelling. We should know that they're using the swelling protocol to do that. Otherwise, we're going to have to say, what did you do? Where did you do? How long did you do it? What was going on? We have to have some kind of consistency in not only how we treat, but we have to have it where it can be then reproducible. So if we're trying to study laser therapy research, it's about reproducibility. So you have to get the same things in your clinic that we get in the lab and that we get in for when we go for FDA approvals and published studies. We want the same type of outcome we get clinically in our lab to match what you get clinically in your practice. Same thing, we have to take variations into account. We have to understand what are these variables that we have to deal with. and where they fall in those different ranges. So there's patient variability, but then there's also variability in how that patient is responding. And then lastly, it provides us a universal method of adoption. It is a way for us to teach because we can't do a protocol or a webinar just exhausting every single condition. If you've ever looked through the PDR, we have PDRs in all medical professions, and you read through the PDR of all the different diseases and injuries and things we have to look at and be prepared for and practice. We can't provide a protocol for every single thing, but we can certainly provide a protocol for how we will approach the symptoms of those particular conditions. So this is the priority principle. So the one thing that we have to understand is we got to know dose. So we've already had our presentation on dose, so we know doses are very important because it's going to tell us, do we upregulate or downregulate? And we have to know the target that we want to treat. So you have to know, is that dose that you're applying going to reach that target? And is there going to be likelihood of a photobiological response? And then that gives us to how we're treating a symptom or a priority, because our goal was not to say we're treating a disease or an illness or an injury. We're saying we're treating a symptom associated with a much larger picture. So the diagnosis becomes less important and the symptomology becomes very important because we're trying to dose based on the symptoms that we're trying to resolve in each state of healing. And if we align those priorities to the stages of healing, we're going to maximize those clinical effects. And that is the basis of the priority principle. So there are 4 stages of healing. There's the acute stage, there's the pain spasm stage, there's the tissue repair phase, and there's also the rehabilitation phase. And these 4 phases, just like any healing, they kind of flow and ebb and they kind of go over, and some people are in some stages longer than others, but we all go through these same stages of healing. So we want to align the therapy and the laser therapy in particular to match the biological needs that we have in these phases. So when we look at this in the acute phase, we always want to deal with very acute injuries. Has the injury happened in less than 48 hours? And our other thing is, are we dealing and modulating pain very well? Pain is a big priority after an injury. And if we're dealing with very, very great levels of pain, 7 or 10 or better, we're talking that they have to find ways to treat that. So in this phase, it's very easy to tell when they're in this phase. That happened less than 48 hours and they're in a lot of pain. They're in the acute phase. So I'm only focused on the treatments that are going to be beneficial to the patient at this phase. We crawl, walk, run. We don't run the first day. We don't have the strength for it yet. So our goal is to say, let's modulate the symptoms that we have in each phase and align the laser therapy to the healing stages of the body. The next stage is pain spasm. And this one's a little bit longer and it's a little bit more involved because we have to control swelling. We have to look at reducing inflammation. We have to talk about reducing muscle spasticity, and we have to continue to reduce pain. And this is really pretty much the first or second largest phase. It's going to happen to be longer. We're going to have to start moving from that acute phase to the subacute phase. And this can last anywhere from several treatments up to several weeks of treatment. It just depends on how that person is responding to the laser, and more importantly, how the laser is promoting and changing the physiology of the body. So our next phase is tissue repair. And this is when we're looking at, once we've resolved inflammation, once we've reduced swelling, we want to start increasing blood flow to the area, and we want to increase the tensile strength of those tissue repairs. So this is the modeling phase that we're going through. And it's one of the last phases that we go through before we start doing functional rehabilitation, which is our last phase. And in this phase, we're worried about things like range of motion and strength. So this is our gait and our exercise and all these things that we want to get to become functional. This is our functional aspect that we want to do. So you can see each stage is pretty distinctive in there. And the one thing that we want to say is stay on target. Always focus. Know what your priorities are in each phase and stage of healing, and know the target for those priorities. Know where you need to treat. So we're going to talk about that. So when you look at the priority principle overall, you can see here's our 4 stages with all of our symptoms that we want to do on the side. So if we're in the acute phase, if you look at this, if I want to manage any type of acute injury for less than 24 hours, Yes, you can see the arrow goes to the right. Yes, I want to treat this. I have this. It's going to tell you, here's the setting inside the device. It's the acute setting. It tells you where to treat it. You treat at the site of injury. And you can see, here's the example. We're going to use a shoulder for this example. And you can see it's my left shoulder here. And I'm going to use the acute setting on any device, on any of the priority principle enabled devices, and treat that. It's pretty simple. That's how my treatment is. It's already preloaded. If I'm going to go through and I have pain greater 7 out of 10, I'm going to treat also at the site of the injury. So I'm going to go through and just do a pain treatment. I'm going to load the pain treatment and provide that treatment to that area. Now, let's say that my pain has gone down. I'm no longer having the acute phase. It's more than 48 hours ago. I'm no longer in that phase. So I'm not going to do those treatments. I'm going to move into the next phase, which is pain spasm. I'm going to want to control swelling. And if I do have swelling, you can see which setting am I going to use? I'm going to use the swelling and edema setting that is in there. And there are 6 locations that we treat, 3 in the upper extremity and 3 in the lower extremity. So when I go to treat this is the shoulder. So I'm going to treat at the axilla. I'm going to treat at the medial elbow and at the radial forearm. And I'm going to treat all 3 of those locations with the swelling setting. Now, if it is the lower extremity, it's the leg, I would do the groin, the popliteal fossa, and the lateral posterior ankle. But I'm going to preload. So my targets, when there's swelling here, if the swelling's in my hand, I have to treat the lymphatics for this. So this is the lymphatics treatment. I don't just run it over where the swelling's at. That's not going to be where the effective, that's not the right target when I'm trying to treat swelling. So after I've treated the swelling, if it's present, now I'm going to go through and reduce inflammation. I'm going to select the inflammation setting, and I'm going to treat at the site of the injury. And you can see, I just go back up in here. So right now, I've treated the axilla, I've treated the medial elbow, and then the lateral wrist. Now I've treated up at my site where my shoulder has the injury, where the inflammation's at. Now I'm going to go through and look at muscle spasms. I select the muscle spasm setting, and I'm going to look for any muscle spasms on the front of the shoulder and also on the back of the shoulder and treat each muscle spasm one time with the muscle spasm setting. Now, if there's one muscle spasm, that means I treat one time. If there's 10, I treat 10 times. It depends on how many spasms you find. And we're going to treat anterior and posterior. And this is no different if I'm doing the knee or the ankle or the wrist. I'm constantly looking for where there's spasticity associated with that joint. Lastly, I'm going to be reducing pain. So if I have treated at the shoulder at the same target for inflammation, I can't treat locally. If there's no inflammation, I can certainly treat here and get reduced pain. But because there is inflammation here, I'm going to come up and treat systemically into the neck. So if I'm treating the upper extremity and I've treated anything with inflammation, because I can't treat the same target twice, I can't treat something for pain and then something for inflammation. We learned that on the dose. We know that that is part of the biphasic dose response. So I have to treat one or the other. If there's local inflammation, I'm going to treat the inflammation first. If there is inflammation present, just go up and treat pain through the neck. There's a target that's available for that. So now, let's just say my shoulder patient's been coming in. They no longer have swelling. Their inflammation is finally resolved. Their spasms are very good. They don't have much of that, and their pain is very minimal. I'm moving out of that pain spasm cycle, and I'm entering the tissue repair phase. And this is where I want to start to improve the tensile strength. I want to start doing movement. I want to start increasing their range of motion. So when I go through here, I want to accelerate their tissue repair. Where am I going to do that target? Same place where inflammation was. I want to go to where the target was, where the injury was, or where it occurred. So I'm going to use the tissue repair setting, treat right over the site of the injury. Then I'm going to go through and I want to increase circulation to that area. So I'm going to find the most proximal arterial pulsation, select blood flow, and apply that to that area. That'll help with that downstream effect of improving blood flow and releasing the nitric oxide that we talked about in previous presentations to help improve circulation. So our patient's doing better. We're at week 3, maybe week 4 at this point when we're treating the patient. Their tensile strength is improved. Their blood flow is improving. We're ready to move into the rehab phase. We want to start doing therapeutic exercises. That's our goal. We want to return function. So now we're going to enter rehab. And you're going to see there's a range of motion loss. So I'm going to select range of motion. And what I'm going to do is I'm going to treat any point along the shoulder joint in at least 2 planes. I'm either going to treat at least the front and the back to make sure, because remember, joints are 3-dimensional. Therefore, I want to treat that. So I'm going to treat at least anterior and posterior, maybe lateral and maybe medial as well, sometimes superior and inferior, depending on your joint. But I want to do at least 2 locations for each joint. Particularly larger joints, I might want to do 4. So depending on that, you're going to treat that. But these are 1 minute per point. These are pretty quick treatments that you're going to see for this range of motion. So lastly, we're going to be looking at muscle strength. So if I have any associated weakness at any of the muscles, I'm going to select muscle strength. If I've got weakness in the bicep, I'm going to apply this dose directly to the bicep. So any of the weakened muscles will get a single dose of muscle strength to help improve that prior to exercise. So we've improved the joint range of motion. We've prepared the muscles for exercise. Now they're ready for the rehabilitation. So you can see how the priority principle walks through each particular phase. Our goal is to stay in phase. So I'm not worried about range of motion or muscle strength if they have swelling, if there's inflammation present, because I'm not adjusting the therapy to the body's physiology, to the stage of healing that they're in. So when you look at this, there are these cardinal symptoms where you have 10 different symptoms that we can treat, but we're not treating all of them at the same time. We're only treating symptoms of the stage that we're in, and if those symptoms are present in that stage. So for instance, for the pain spasm, you don't have to treat swelling, inflammation, muscle spasm, and pain for each one if they don't have that. So you can have swelling and very little pain, almost no muscle spasm, and you could have no inflammation. You can have swelling. So do you have to do the other protocols? Absolutely not. The patient has to present with that symptom during that time. However, we do not want to move along if one of those cardinal symptoms is still present. I don't want to move away. Something's causing the swelling. I don't want to bring more blood flow into the area in the tissue repair phase because I'm going to increase swelling again. So stay in your phase as you go through for the healing. So let's talk a little theory into practice. So, keep calm. It's very easy. It's going to be super easy for you to learn this, to use the laser. So let's talk about a 42-year-old male. He has an acute left ankle sprain. His date of injury was 1 day ago. He complains of 7 out of 10 pain. He complains of swelling. He has difficulty walking and tenderness around the lateral ankle with bruising. So what are you going to prescribe for your laser therapy dose? Well, I could certainly see from his symptoms, he's got pain, he's got swelling, he's got range of motion loss, and he has a lack of circulation. But which symptom, where is he going to be? Because it happened a day ago, he is in the acute phase. So I'm not worried about what's going on with the swelling. I'm not worried about what's going on with the walking. I'm not worried about the bruising. What I'm worried about now is modulating that inflammatory process by treating the acute phase. And where am I going to treat him? As you can see in the blue box, I'm going to treat him at the site of the injury. So what other protocol? If this was a knee sprain, if this was a finger sprain, if this was a shoulder sprain, if it happened 1 day ago, the protocol will be load the acute setting and treat directly to the area of the injury. So let's take another example. Let's take a 60-year-old female who has tendinitis in her right elbow. This happened 35 days ago, so you know already. The minute I said the date of injury is less than 35, greater than 35 days ago, you know you're not in the acute phase. She's complaining of pain, 6 out of 10, stiffness upon movement, range motion loss, tenderness with grip, probably some strength loss, painful range of motion, reduced grip strength, tenderness along there, inflammation, you can feel some heat, and spasm in the extensor muscles. So where do we think we are? We're 35 days out from that injury, but we are in the pain spasm cycle very clearly. There's inflammation noted, there's muscle spasm, and there's pain. Why am I not doing swelling? There wasn't a symptom. She doesn't need the swelling, so her protocol would be treat the muscle spasm, treat the inflammation, and because there is local inflammation, which setting am I using for pain? Am I doing the one where I treat the same area, or am I going to go treat a secondary area? Well, I don't want to do the same treatment in an area twice. So I have to do inflammation locally to the elbow, and I'm going to come up and treat the cervical spine. Now, if this was the knee and I had inflammation in the knee, where am I going to treat for the secondary spot for the back? For the knee, I'm going to treat it up in the back. So it kind of allows that to happen. So let's take one more example. Let's do a 22-year-old female with postoperative ACL repair in her left knee. This happened 65 days ago. So again, we are certainly not in the acute phase. Her complaints are pain 4 out of 10. She has stiffness upon movement. She has instability during gait. There's no swelling or heat. She has no spasm really in the muscles. There is muscle weakness though and limited range of motion, but the repair has not fully healed. So she's doing pretty good. You did a fantastic job. You got her out of the acute phase. You moved her through pain spasm. So is she in the tissue repair or is she in range of motion? Well, you can see there's a lot of weakness. She's having a difficulty walking. She hasn't had the repair long enough that we feel that we can start doing active exercise and aggressively starting to give mobilization and range of motion. So we are in the tissue healing phase. So we're going to do tissue repair and blood flow. We're going to do tissue repair right to the injury, right where the surgery was done, to improve the quality and tensile strength of the ACL, blood flow to improve her overall healing. Now, one thing I just want to say to you, just you need to know where that proximal artery is. And just so you know, for the back of the knee, it's at the back of the knee. So we have to treat there through the back, just as a little side note. Now, what's interesting, the priority principle also works for veterinary indications. So let's just say I have a 5-year-old German Shepherd with hip osteoarthritis, left greater than right. Happened 3 months ago. Difficulty walking, tenderness at the joint, palpation, weakness in the hind muscles with associated spasm in the lumbar region, limited range of motion of that left hip. Where's this patient at? Well, you can easily see the patient is in the pain spasm cycle. Why? Because there's inflammation, muscle spasm, and pain. So you can see this is actually the same protocol that I was using in the human model. We are still looking after the symptoms, looking at the physiology that's going on. So why am I not treating swelling in this patient? Because it's not a symptom. So I'm only going after the muscle spasms. I'm treating inflammation locally, and I'm treating pain systemically through the lumbar spine. So I want to give you a little bit of tips and tricks here. So just so you know, when we're using the acute setting, you can repeat this every hour at the site of the injury. So it's a little bit like using ice. That's the way we kind of explain it. So we want to modulate that inflammatory response. With swelling and edema, always start proximal and move your way to distal at any lymph site. You can do a little bit of scanning, but if you do, you start at the proximal location, but you scan distal to proximal. You move towards the body, never away when you're scanning. Inflammation, don't overtreat this. Treat at the site of inflammation, use the laser stem, certainly use WellView to help identify areas where inflammation is present. For the muscle spasm, use the trigger point probes. Fantastic. It's a great way you can apply overpressure. You can get a stem along with it. Pain, treat systemically when inflammation is present. Okay, so you have to go through and treat that. If it's there, you've got to make sure that you're going to treat systemically, right? So in tissue repair, don't overtreat this, only treat once per day. This is the more is not better. We do not want to overstimulate that because the energy requirements of the tissue during the healing phase are starting to drop off. So by increasing that frequency, we can oversaturate that by the cumulative dose. Blood flow, remember, proximal arterial pulsation, and it's really to increase blood flow and oxygenation to that tissue, but you have to know where that is. You want to go where as close the artery is to the surface. So it's basic, it's simply basic anatomy. You just have to understand where is that artery at, where you're going to take a pulsation at. When you're looking at range of motion, use a utility probe, use a general probe. Remember multiple projections along the joint line. You have to do at least AP, but you may want to do lateral as well. For strength, you want to apply the light therapy or the laser before exercise to the muscle belly and to each muscle belly that you're exercising. Otherwise, you're going to get an incomplete effect as well. So one thing, I don't know. I don't know. You go into the doctor's office and he says, tell me how I'm going to treat this. What is my treatment? How am I going to do this? Tell me, please. So the thing is, all you have to do is ask qualifying questions. You just have to ask. And the first question is, did the injury happen in the last 48 hours? If it did, You know what phase you're in. You're in the acute phase. Then you're going to say, is there any swelling or edema? Does it feel warm to the touch? Is there any redness, itching? Can you see inflammation on the well view? Is the laser stem picking this up? Can you palpate any spasms? Are they walking in? Is their arm locked? Are they guarded? Are they doing muscle guarding? What is their subjective pain? How do you feel today? What's your pain level today? And then would the tissue benefit from additional healing? Are you at that point? Are you going through either a post-op rehabilitation? Are you going through like a frozen shoulder? Like, would the tissue benefit from having increased tensile strength? Would the tissue benefit from additional circulation? Do we need to bring blood flow back in here? Is this an area? Are we having patients who have hypoxic areas? Do we have people who have peripheral artery disease? What do we want to do? Do we want to increase the oxygenation to a particular tissue? If the answer is yes, it's great. Is there limited joint range of motion? That's an easy one. Lift your arm up. Let me see how your shoulder's moving. Let me see you walk. We can tell if they have limited range of motion. And is there any associated weakness? Is there limping? Is there any things that they're not doing? Can they not jump? So it allows us to kind of go through and you can figure out where the patient is very quickly by asking these pointed questions. They're very directed to that. Simply, what do you want the laser to work with today? So where do you find the priority principle? In all of our products. It is the bridge between everything. It's in the Activette, it's in the Active Laser Shower, it's in the Activette Pro, it's in the Active Laser as well in the Laser Shower, it's in the AlphaVet, it's going to be in the Alpha. So it is everywhere. The priority principle is symptom-based. Just remember that. We're looking at what symptom are we treating? What do we want the laser to do today? It's not based on the diagnosis. This adapts the protocols to the patient's current physiological and functional requirements. You've got to match the treatment to the stage of healing. If you don't, you're not going to see the same results that you want to. Considers patient variability. This is a big deal. We have to understand where the patient is, what other comorbidities are they having, what other symptoms are they developing or that they have that we have to address. It helps us to consider that. Where is that patient in their healing phase? It's now a universal language across multiple disciplines. When we talk these symptoms are universal. They're cardinal symptoms for a reason. We all have them. All animals have them. Everybody has these. So that way we can actually talk between disciplines to say, did you treat swelling? Did you treat this? Because now we can look at what the diagnosis is, look at what it is in the PDR, understand the pathophysiology behind it. We can now start to come up with a plan of attack for the laser. It ensures consistency. The biggest thing, consistency. It's going to minimize errors and enhance efficacy because we are following a systematic question. Is there swelling? Is there inflammation? Is there muscle spasm? Is there pain? We're asking a set questions to the same patients to make sure we're actually adapting the therapy to it. It works both in medical and veterinary. It acts as a bridge between all of our products. They're built into everything. So you can use the priority principle whether you have an alpha, whether you have an active or an Activette. And it preloads the right photoceutical dosage for the intended target. So the only thing that you have to do, once you've loaded that I'm treating swelling, the only thing is you have to just make sure it goes on the right target. So the only thing you have to remember is where these targets for these 11 symptoms are. So you have to know if I'm treating a muscle spasm, you probably want to put the laser on a muscle spasm. I have muscle strength weakness. Where should I put the laser? I should put the laser on where there's the weak muscle. So the only thing that you have to keep remembering is in the acute phase, we treat local. We treat where the injury is. We do the same thing for inflammation. It's treated locally. Tissue repair is treated locally where the injury is. And when we treat inflammation locally, we have to treat pain systemically. We have to go up where we talked about where centralization occurs through the spine, where we know we get that transmission. We have to block that transmission so we can treat up through the dorsal nerve roots. And lastly, this is really about getting consistent and reproducible patient results. This is what we do in the clinic. This is what we do in our research. This is how we're going to do this in clinical practice. So stop guessing, start knowing. You've got that ability to be able to help people to start looking at what they're going to and how they're going to prescribe their laser. It's no longer just a point and shoot. We don't have to do that. We have a level of precision and understanding of how the wavelengths work together, how our technology works. More importantly, we've got a way of how we can apply that. And just know it's just the priority principle. Super easy. Once you learn this, you're going to be able to see that the world will open up and you're going to be able to help people at least get a starting point. One thing we want to do is we teach priority principle often on our webinars. So it's a great way for you to start understanding, being able to give people direction and then pointing them in to say, look, we're going to learn this new language together. So hopefully you learned something from this series of laser lectures, and hopefully we will talk again soon.